Discuss very important topic, sodium, potassium and chloride. This is not only help you in your biochemistry lecture classes, but it will help you in future as a practitioner, as a doctor. If you have this knowledge, you can save lot of patients' life. Understand? So, in hospital setup, the disbalance of sodium and potassium and chloride is very common in patient admitted in ICU or emergency or IPD. Even some patient come to you in OPD with this disbalance of sodium, potassium or chloride like this. When you start practice, I seen lot of doctors actually they have forgotten about this problem. So keep in mind, this is one of the most neglected thing in our day-to-day practice. So if you have this knowledge in your mind, you can save lot of patients' life. In your biochemistry lecture classes, you may get very short note or maybe part of a long question as a short note. This is not so much important for your passing exam. But as a future doctor, this is very important. Remember this. Okay? So start with sodium. We are going to discuss under these headings both sodium and potassium, like recommended dietary allowances, sources, function, distribution, regulation and disorder. In this heading, sodium is one of the most abundant mineral present in our body. It present in extracellular as well as intracellular, but it mainly present in extracellular space. Normal serum sodium level, just remember, you may ask in the Viva exam, what is the normal value of serum sodium level? Remember 135 to 145 milliequivalent per liter or millimole per liter, both are same. It mainly present in extracellular space, that is outside the cell. Inside cell, the amount is very less. 10 to 12 milliequivalent per liter. All of the cells in our body have sodium, potassium, ATPase pump. Have you heard the term? Sodium, potassium, ATPase pump in your physiology lecture classes? Anyone response? Sodium, potassium and ATPase pump kept sodium outside, always. It kicked out 3 molecules of sodium outside. In response, they return 2 molecules of potassium inside. And it requires energy because in outside there is sodium concentration very high, inside very less. So if you have to, like example, you have to go upward, then you require energy. By this way, it requires energy to keep from inside to outside. Energy comes from ATP. Normally, sodium is not permeable to go inside. It goes only when the nerve impulse comes in the form of depolarization and repolarization. Probably you heard in lecture classes in physiology. Depolarization, nerve conduction, okay, action potential. Have you heard the term? By this way. So by this way, all the cells in our body try to keep sodium outside and keep the cell in polarized form. In polarized form, normally cell is become intracellular negative. Okay, by keeping sodium outside, and there is lot of negative charge protein present inside the cell. Our body contain 3,500 to 4,000 milliequivalent sodium, out of which 50% present in the bone, 40% present in extracellular space, extracellular fluid, and 10% present in soft tissue. Out of them, 75% are in exchangeable form. They can exchange. That is, they go inside cell, they can come out from cell also. Rest 25% are non-exchangeable form, present in bone. In normal diet, we consume sodium mostly in the form of sodium chloride, that is salt, okay, up to 5 to 10 grams. But the same amount can be exceeded through urine by kidney. But in our body, kidney can preserve sodium up to 99% can preserve, because sodium follows water, so it maintains blood volume, fluid volume. Kidney preserve sodium but excrete potassium. I am coming later. Majority of sodium are reabsorbed from proximal committed tubule of glomerulus, and this is an active process. That is, it requires energy. Okay, as I told earlier, sodium follows water, so sodium reabsorption is primary and water is secondary. Next, sodium oxidation is regulated in distal tubules, and aldosterone is a hormone. It reabsorbs sodium from distal tubules as well as collecting duct. Aldosterone is secreted from anyone? Secret from बोलते बाबे aldosterone is secreted from which gland? Suprarenal gland, from zona glomerulosa. There is 3 layers in suprarenal gland: zona glomerulosa, zona fasciculata, zona reticularis. You heard in physiology classes. Okay. And another thing is antidiuretic hormone ADH. It also reabsorbs water from tubules, renal tubules. Different mechanisms are sodium hydrogen exchanger located in PCT and ascending limb of healthy, sodium chloride co-transporter in distal tubules, sodium channel in collecting duct, and sodium potassium exchanger in the distal tubules. Rate of sodium absorption depend on GFR. If there is less GFR, there is less sodium absorption, and also blood pressure. And this is mainly dependent on one system, very important system, that is called RAAS system, RAAS, renin-angiotensin-aldosterone axis system. I am coming later, just concentrate here. Recommended dietary allowances: WHO, there is World Health Organization, suggests to limit sodium intake, there is salt intake less than 2 grams per day, because sodium retains water. As a result, blood volume increases, blood pressure also increases. However, normal diet contains 5 to 10 grams of sodium, mainly as sodium chloride. Sources mainly salt. Apart from that, food contain plenty amount of sodium like cereal, milk, egg, meat, fish, etc. Apart from that, anyone love to take fast food? Fast food contain lot of sodium chloride. Fast food, Maggi, Chow-mein, have you heard the term? They are using plenty amount of sodium chloride. So try to consume less. Normal plasma level, as I told earlier, just remember this: 135 to 141 milliequivalent per liter. This is normal level. Intracellular level, 10 to 12 milliequivalent per liter. It can be measured by ISE. Just remember this: ion selective electrode. In modern laboratory, we are using this technique, ion selective electrode technique. Even though fully automatic analyzer they have inbuilt ISA. Okay. Apart from that, it also can be measured by enzymatically. You don't have to remember, just remember this. You can also measure by this method enzymatically. Just remember this. Apart from ISE, this is very important. Function of sodium. Sodium is maintain plasma volume and plasma osmolarity. What is osmolarity? Presence of solute, especially ion, present in serum or plasma. More amount of solute means more osmolarity, less means less osmolarity. Normal value 280 to 295 milliosmol per kg. Just remember this. 280 to 295 milliosmol per kg. Okay. The sodium maintain plasma osmolarity. Maintenance of acid-base balance in the form of bicarbonate buffer by lungs. Okay. Sodium hydrogen ion exchanger by kidneys, and all of the cells in our body have sodium-potassium pump and require energy. There is it is called as sodium-potassium ATPase pump. This throws out 3 sodium molecule. In return, they take inside 2 potassium molecule, the potassium ion, whatever itself. And very important thing is it absorbs glucose, galactose and amino acid from intestine. It is also called as SGLT1 transporter, present in intestinal mucosa cell. And in kidney, it is called SGLT2 transporter. Nowadays, we are using SGLT2 inhibitors. Some drugs are there, like dapagliflozin, canagliflozin. Just remember this, just heard this term. Dapagliflozin, canagliflozin, etc. This kind of drug, they inhibit SGLT2 transporter. By this way, body unable to reabsorb glucose by kidney. So by this way, we prescribe these drugs to treat diabetic patients. Okay. Etc. Canagliflozin, dapagliflozin, these are SGLT2 inhibitor drugs. They inhibit this transporter, SGLT2 transporter. By this way, lost glucose via kidney, and it is used in treatment of diabetic patients. So as you know, diabetes is one of the most leading cause of morbidity and mortality. So nowadays we are increasing this. You will read in pharmacology classes later in second MBBS. Okay. So continuing our lecture. Apart from that, sodium is also used as a part functional in nerve muscle conduction by the form of action potential generation. Okay. This is most important slide. Just remember this. Next. Any question till now? Okay. Regulation of sodium in our body. So remember this very important RAAS system. So how RAAS system works? When there is less amount of blood flow in kidney by decreasing GFR. Anyway, if our body sends blood loss or volume loss, there is activation of stem cells present in nephrons. They are called juxtaglomerular apparatus cells, and they contain one enzyme that is called renin. R-E-N-I-N. Okay. So there is decreased GFR anyway in the form of blood loss or volume loss like diarrhea, vomiting or excess sweating or blood loss by hemorrhage. What happened? There is less GFR and inactivate juxtaglomerular apparatus cells present in glomerulus in nephron, and they contain enzyme called renin. Renin are actually enzyme. They release in circulation and then they convert angiotensinogen. Angiotensinogen, which are released from liver in inactive form. Inactive form, renin convert angiotensinogen to angiotensin 1. Okay, angiotensin 1 and then convert into angiotensin 2. By enzyme which are secreted from lungs, ACE, angiotensin converting enzyme. They convert angiotensin 1 into angiotensin 2, and angiotensin 2 has various receptors present in our body, like they present in blood vessel that causes vasoconstriction. Okay, they present in suprarenal gland, in zona glomerulosa, and when they stimulate these cells, they release aldosterone hormone. Okay, aldosterone hormone, they reabsorb sodium from distal tubule as well as collecting duct. By this way, body preserves sodium and also water and throw out potassium. Okay, by this way, body conserves sodium as well as water, blood volume maintained. This is one of the most important topic, no? Not only biochemistry, in physiology, in pharmacology, in medicine, everywhere you have heard this term, RAAS system. So we have also some drugs. It blocks the aldosterone. Example, spironolactone. Just heard this term. Just listen this, spironolactone. This drug can inhibit aldosterone receptor. So by this way we can stop this system. Okay. So again, RAAS system. This is a beautiful system. When there is decreased GFR, this senses juxtaglomerular cells present in nephron, and they contain renin. Renin is an enzyme, and they come in circulation Another molecule is there in circulation, that is angiotensin released from liver as inactive form. Renin convert angiotensin into angiotensin 1, and again they start circulating and reaches in lungs. There is another enzyme there, that is called ACE, angiotensin converting enzyme. ACE convert angiotensin 1 into angiotensin 2. Angiotensin 2 is barrier receptor in our body, like blood vessel. In the blood vessel, they causes vasoconstriction. By this way, blood pressure increases. The receptor in adrenal cortex causes release of hormone called aldosterone. Cholesterol, they come in circulation, reaches in kidney, where it reabsorbs sodium and excrete out potassium. Okay. By this way, body can preserve sodium as well as water. Sometimes this system also causes problem in ourselves also. They causes blood pressure. So one drug is there called spironolactone. It can block this system. What is the fate of angiotensin 2? It combines to angiotensin 3. It is inactive form and they degrade. Okay. Next regulation is ANF, atrial nativity factor. When there is increase of blood volume, it causes stretching of right atrium, heart. And atrium releases a hormone called atrial nativity factor. Atrial nativity factor causes excretion of sodium. Okay. ANF. Any question till now? Everybody understand this concept? RAAS system? Okay. Let's proceed. So disorder of sodium. Remember, sodium normal value is very important. Just remember this, 130 to 145 milligram per liter. When there is less than 135, there is called hyponatremia. So if we have a patient, we get 130 sodium. The patient is absolutely normal. You may wonder, it is hyponatremic, but till it works, there is no any symptom. Answer is body can cope up just when there is decreased amount of sodium value less than 135. Body can cope up until unless it is very low, like 125. Then clinical symptom appears. It also depends for duration. Say a patient is bedridden patient for prolonged time. Patient is bedridden. They taking very less amount of sodium, water. The patient is hyponatremic. If you test, if say found 120, till patient is symptom free, body can cope up. But when hyponatremia develops very fast, like 1 or 2 days or 3 days, then symptom appears. For the symptoms, first symptom is, as I told earlier, it maintain blood volume, cellular integrity also maintain. Okay. First appearance of symptom is brain, nerve cells. Patient may come with confusion, dizziness, even convulsion with hypernatremia. This is the first symptom. So any patient you found suffering from severe diarrhea or vomiting, just check this value. Serum sodium ion level, potassium ion level, chloride level, all are three importance. When there is water loss by diarrhea, vomiting or severe sweating, patient may suffer sodium loss, potassium loss, chloride loss, like this. Okay. So, as I told earlier, sodium also maintain osmolarity. Though you have to change osmolarity also. Normal osmolarity value 280 to 295 milliosmol per kg. Okay. So our treatment start like this. Hyponatremia patient is diagnosed. Then C, normal osmolarity with hyponatremia. Some condition like hyperlipidemia, hyperproteinemia like multiple myeloma, or paraproteinemia like cancer patient. Okay, this is one condition. Next is increased osmolarity with hyponatremia, like hyperglycemia, like patient is diabetes, uncontrolled diabetes. Patient has uremia, like patient acute chronic renal failure, urea level very high, uremia. Or patient is receiving mannitol therapy. This is one therapy we use in patient suffering from cerebral edema, any sort of cerebral edema like stroke. Okay, we use mannitol therapy. So mannitol therapy causes increased osmolarity with hyponatremia sometimes. So patient receiving mannitol therapy we also monitor serum sodium level. Okay. Next is decreased osmolarity. Then you have to see patient is hypervolemic or euvolemic or hypovolemic. Hypervolemic condition like congestive cardiac failure, cirrhosis of liver, nephrotic syndrome, chronic renal failure. These are examples. Everyone take this picture also. Very important slide. Okay. Next is euvolemia. Patient is volume normal, but patient is suffering from hyponatremia. Condition like SIADH, syndrome of inappropriate antidiuretic hormone. I am coming later. Just remember this term. Listen this term. Example like pneumonia, bronchial cancer, hypothyroidism, hypoadrenalism, etc. And last one is hypovolemic, like dehydration, any sort of dehydration, like vomiting, diarrhea, burn, excess sweating, mineralocorticoid deficiency, diuretic therapy. Okay, patient is suffering from hypovolemia with hyponatremia. The patient is not receiving oral sodium chloride with water. Then they proceed this kind of problem. Okay, so any patient you found with diarrhea, vomiting, what the first prescription? First suggestion, RAAS. If the RAAS is not available in your home, then they make a RAAS, just like pinch of salt and slight sugar with water. Okay. Okay. Next, so first symptom is hyponatremia. Next is, this is SIADH, syndrome of inappropriate antidiuretic hormone. So these are the symptoms. We must have to follow this, to remove this criteria like hyponatremia, decreased osmolarity, urine sodium more than 20 and urine osmolarity more than 100. That is urine losing sodium also with the hyponatremia as well as decreased osmolarity. Next, causes of hyponatremia. This is a very big list. I take it from Vasudeva. We can go through this. Okay. Next, hypernatremia. Again, we have to see blood volume. If they are hypervolemic, condition like Cushing syndrome, mineralocorticoid therapy. Euvolemic, like diabetes insipidus, either central or nephrogenic diabetes insipidus. Next is hypovolemic, like vomiting or diarrhea with decreased water intake, diuretics with decreased water intake. Okay. These are some causes of hyponatremia. Again I am taking it from Vasudevan, again go to this. Okay. So in sodium you have to remember hypernatremia. You have to remember SiADH. You have to remember normal value of sodium, serum value. Okay. Hyponatremia, some causes. Hyponatremia, some causes. What is the serum osmolarity level? You have to remember this. Okay. You have to remember again this one also very important. RAAS system. Next, potassium. Potassium present mainly intracellularly. In intracellular area, potassium very high, up to 160 milligram per liter. But outside, very less. Serum potassium value, normal value, 3.5 to 5 milligram per liter. Potassium mainly present inside cell, so any sort of cell injury like muscle injury, crash injury, road traffic accident with muscle injury, you may found high level of potassium in blood. Total body potassium up to 3500 milligram out of 75% in skeletal muscle. It is a major intercellular cation and maintain intercellular osmotic pressure. It also take part in depolarization and repolarization. The conduction of heart require potassium. It is also part of sodium potassium ATPase pump. Minor changes in potassium has profound effect in heart also. Heart contractility. Okay. So make a habit. If there is potassium disturbance, you have to see the patient's heart. How can you see? Seeing ECG changes. I am coming later for the ECG changes. Next, daily requirement up to 3 to 4 gram. Dietary intake 20 to 200. 1 milligram is equal to 39 point, most probably 2, I not remember, milligram. Okay, by this way you can calculate. Sources: banana, orange, apple, pineapple. Mainly fruits contain plenty amount of potassium. Tender coconut water, Dove. Have you heard the term Daverjol? Nariyal pani. Have plenty amount of water, potassium. Especially young coconut. Tender coconut water contain potassium, rich source of potassium. So if you found patient is suffering from hypokalemia, you can prescribe tender coconut water also. Not prescribe, but tell them to drink lot of coconut water. Normal value and plasma level 3.5 to 5 milligram per liter. Please remember this, everyone. You may ask in the Viva exam. Intercytoplasmic value 160. See, the difference is very high. Here also we use this method, ion selective electrode method, ISE method. Also can be determined by sodium dependent pyruvate kinase activity. This is also enzymatic method. Okay. Next, potassium excretion mainly via kidney and some extent with GI. Also some extent by sweating. Kidney hormone is aldosterone. Aldosterone retains sodium and excretes potassium. Apart from that, sodium potassium exchanger. Kidney can lower renal excretion 5 to 10 mol per day or increase secretion to 250 mol per day depending on the potassium intake. Aldosterone and corticosteroid increase excretion of potassium. Aldosterone and corticosteroid, remember this. kidney excrete mainly 90% and rest 10% through GI2. Some extent with sweating. When there is an increase in hydrogen ion concentration of extracellular fluid, there is a redistribution of potassium. So patient is suffering from acidosis, any form, metabolic, either metabolic acidosis or respiratory acidosis. Patient may suffering from hyperkalemia also. Hydrogen go inside cell and come out from cell. By this way, patient may suffering from hyperkalemia. Patient with chronic kidney disease, because kidney excrete potassium. So when there is disease in kidney like chronic renal failure, kidney unable to excrete potassium. As a result, what happens? Potassium start to retain in our body, and patient may suffer hyperkalemia. And by this way, patient may die because of hyperkalemia. If we cannot treat early, patient may die. In hyperkalemia, in chronic renal failure patient, this is one of the cause of death, hyperkalemia. Okay. Next, another very important slide. You can take picture. Biochemical function. Regulate intracellular volume, maintain resting membrane potential and depolarization, nerve muscle transmission, part of sodium-potassium pump, secretion of hydrochloric acid in gastric juice, and sometimes potassium activates some enzyme like pyruvate kinase, some enzyme. Okay, this is another important slide. Function of potassium. Disorder again. Potassium normal value 3.5 to 5 milliosmol per liter or milliequivalent per liter, both the same. When there is less than 3.5, there is called hypokalemia. Clinical symptom appears when there is less than 3. The value less than 3.5 is viewed to be with caution. Hypokalemia clinical manifestation: muscle weakness, fatigue, muscle cramp, hypotension, decreased reflexes, palpitation, cardiac arrhythmia, cardiac arrest. When we work in IPD, we use stethoscope to listen the peristaltic sound. If there is peristaltic sound very less, you can suspect patient is suffering from hypokalemia. Even some patients develop swelling of abdomen, as because there is less peristalsis, there is retention of food stuff inside intestine, and it causes bacteria to ferment food and produce carbon dioxide, lactic acid. Okay, this is one clinical bedside clinical diagnosis to suspect patient suffering from hypokalemia. Just using stethoscope, you can suspect patient suffering from hypokalemia. Okay, sometimes even found in OPD. I have one experience. A few months ago, one patient come to me. He was suffering from diarrhea for 7 to 10 days ago. Severe diarrhea, 15 to 20 times motion per day. Then he started taking RAAS, some other antibiotics, probiotics like this. But till he was unable to walk properly, he was fatigued, he was having muscle cramping. When he came to me, I suggest to go for electrolyte test, sodium, potassium. After seeing the potassium value was very less, 2 milliequivalent per liter, very less. By this way, you can suspect hypokalemia. And then I suggest him to take coconut water, fruits. Even nowadays, some solutions are available. pot chloride syrup, commercially available, potassium chloride syrup. You can prescribe them to take pot chloride syrup along with fruit juice or water, drinking water. So this is the first symptom of clinical symptom. And ECG, you have to look for ECG. What is ECG? Have you heard of ECG? Electrocardiography. Okay. This is graphical representation of electrical activity of heart. ECG. In ECG we have P wave, QRS complex, T wave, like this. So this is a case of like picture of ECG. This is P wave. This is QRS, P, T wave, sometimes U wave. Okay, the arbitrary picture. So in ECG, T wave is become inverted. That is T wave. This is T wave. T wave. It become inverted. That is it like this. It go like this. Inverted. ST segment lower. This is called ST segment. ST segment. It become lower. Become it go downside. This is baseline. Say this is like this. Okay. With AB block, antiventricular block. This is P wave. This is called P or interval. This is QRS complex. QRS complex. This is T wave. So, if you found a patient like this kind of symptom like muscle weakness, you prescribe one BCG and found this kind of thing. Thin body T wave, decrease lowering of ST segment. You may suspect hypokalemia. Patient suffering some diabetes, we prescribe insulin. Insulin also pushes potassium inside cell, causes hypokalemia. Okay. Metabolic acids causes hyperkalemia. Metabolic alkalosis causes hypokalemia. Opposite. Okay. Remember this. Alkalosis, potassium move into the cell, exchanges to extracellular proton. Insulin therapy causes hypokalemia. Okay. Hypokalemia. Next, hyperkalemia. These are causes of hypokalemia. Very long list. I have also taken from Vasudeva. Just read this from your textbook. Very important slide. Okay. Next, hyperkalemia. When potassium level reaches above 5.5 mol per liter, it is known as hyperkalemia. Hyperkalemia is also very dangerous. Even hyperkalemia much more dangerous than hypokalemia. Why? It blocks heart, almost blocks heart. How? Say this is T wave. When there is start of hyperkalemia, this T waves become peak like this, tall P wave. You can septic hyperkalemia. Next, this QRS complex started widening. Okay, and eventually T wave lost. When there progressive hyperkalemia, if you do not start treatment, T wave lost, and it become like this. This is called sine wave pattern. T wave become prominent when early phase of hyperkalemia. And this QRS complex, it become widened, started widening, and eventually when progressive hyperkalemia, the peak will be lost, T wave lost, and last of all it become this kind. Heart stop generating impulses. The patient may die. Everyone should remember this Fact, hyperkalemia, ECG change, very, very important. As a MBBS doctor, you have to remember this. There is no excuse. In hyperkalemia, there is increased membrane excitability, which lead to ventricular arrhythmia and ventricular fibrillation. Hyperkalemia characterized by flaccid paralysis, bradycardia, and cardiac arrest. ECG shows T-wave widening of T-wave, peaking of T-wave actually, widening of T-wave complex, and then your PR interval. This is called PR interval, it become prolonged. And ultimately this kind of sign, this is called sign pattern. This is a dangerous sign, very difficult to save the patient when reach this condition. Okay. This is a list, go through this book. And this is reduction of potassium. Causes of increased potassium entry in cell leading to hypokalemia like insulin therapy, beta-adrenergic stimuli, alkalosis. Causes of impaired potassium entry cell or exit from cell, like glucagon, alpha-adrenergic stimuli, acidosis, increased osmolarity. Okay. Treatment, hyperkalemia. As I told earlier, insulin pushes potassium inside cell, so you start dextroid with insulin infusion. Okay. Next is you can use sodium bicarbonate or calcium gluconate therapy. As the hyperkalemia, along with metabolic acidosis, you can use sodium bicarbonate infusion to correct acidosis. Sometimes you also use inhale salbutamol. Salbutamol pushes potassium inside cell. Salbutamol is used for bronchial asthma treatment. And in extreme form, patient may go for dialysis, hemodialysis, peritoneal dialysis. Okay. Most patients suffering from chronic renal failure or acute renal failure may develop hyperkalemia, so they may require dialysis for treatment. Okay. Next, very short. Chloride is very short. Chloride, just read this from your textbook. Homeostatic sodium, chloride, and chloride are interrelated. Just remember, all three are interrelated. Sodium, potassium, chloride. Normal value is 96 to 106 milligram per liter. In CSF is 125 milligram per liter. This is normal serum value. This is CSF value. Okay. Excretion chloride is through urine and parallel to sodium ion. Renal threshold is 110 milligram per liter. Okay. Chloride concentration. Plasma, as I told earlier, 96 to 106. CSF 125. Daily excretion 5 to 10 gram. Renal threshold 110 milligram per liter. Okay. Hypernatremia, seen in dehydration, Cushing syndrome, where mineral corticoid causes increased reabsorption from kidney tubules. Severe diarrhea, which leads to loss of bicarbonate and compensatory retention of chloride. Adrenal tubule acidosis is another condition. Hypokalemia, excess vomiting. By the way, we lost hydrochloric acid with vomiting. By this we lost chloride. There is compensatory increase in bicarbonate. This is called hypochloremic alkalosis. You also heard in reading medicine book, textbook later on. Excess sweating, rare cause. In addition, disease, aldosterone is diminished, renal tubular resorption of chloride is decreased, more chloride is excreted. In addition, disease, hypokalemia. And this is one important, just remember this, cystic fibrosis, one disease where chloride channel is defective. This is one disease because of point mutational CFTR gene resulting in defective chloride transport. So water moves out from lungs and pancreas, and this is responsible for abnormal thick mucus. This leads to progressive damage of these vital organs by deposition of thick mucus plaques which attract infection and death at young age. Cystic fibrosis. Just remember this term, CFTR gene and chloride channel defective. This is one disease. Okay. Thank you.